I'm Daniel Swartz. I'm the Director of Metabolic and Bariatric Surgery at St. Agnes Medical Center. I've cared for over 10,000 patients undergoing the surgery. I've personally performed over 6,000 of these operations, but I've performed many other surgeries related to bariatric surgery. What I find most fulfilling working with these patients is watching each individual patient's transformation. Before they have surgery, patients who suffer from morbid obesity, that is a really difficult disease to suffer from. Their health is spiraling out of control, new diagnoses, more medications, and they can't really do the things they want to do. They can't go on hikes with their family, they can't get down on the floor and play with their kids and their grandkids, and they're depressed. It's not an easy life. And when you watch what happens to people after surgery in the months and years, and you watch people achieve incredible weight loss and go off medications, and their diseases go away or get so much better, and they get their lives back, and they can go on hikes with their family, and their family can't keep up with them, and they can walk all day at Disneyland, and they could sit comfortably in a movie theater or an airplane or buy clothes off the rack. They get their lives back. They're just so happy. And even though from studies we know that they live longer and they live more productive and they're less likely to incur medical costs from diseases, what's really fulfilling is hearing each individual story. The reason obesity is such an epidemic in this country is, well, let me say it's multifactorial. There's a lot of reasons, and I don't think anybody knows exactly why. It's an epidemic that we began noticing in the mid to late 1970s, and it has just spun out of control in then. So something must have happened in the 50s and 60s for this to have started. It's possible that it's our diet for a lot of it. We're eating a lot more processed foods. There's more sedentary activity with the advent of computers in everyday life. Since that time period, people are sitting more glued to their screens. They're not exercising like they should. Life is more stressful. People are losing sleep. They're on medications that have a side effect of weight gain. And I think it's the whole constellation of those reasons and probably others we don't know, but there's no question we're in an epidemic. It's not just an epidemic in this country. We're seeing this around the world, and we're seeing this in developing nations too. It's a worldwide pandemic. So we consider obesity to be a disease. It's not a lifestyle, it's not a psychologic aberration. It's a disease because it leads to reduced life expectancy by 8 to 10 years. If you have severe obesity, it leads to significantly higher rates in medical problems such as diabetes, high cholesterol, high blood pressure, cancer, heart attack, stroke, acid reflux, joints giving out, days off work. And it's part of a disease we know of as the metabolic syndrome. When you have high cholesterol, diabetes, high blood pressure, and waist circumference, you're at so much risk, more risk for cardiovascular disease and early death. There is no question this is a disease. The people who are afflicted with it are much less healthier than those who do not. The way we determine candidacy for surgery is, first of all, based on body mass index. You would need a minimum body mass index of 40 in the absence of any other medical problems in order to qualify for surgery. If your body mass index is between 35 and 40, you would need at least one or more obesity-related medical problems, such as diabetes, high blood pressure, sleep apnea, acid reflux. Now, even if you meet the criteria, you're not necessarily a candidate for surgery. We look for patients who have actually tried to lose weight. We are looking for people who have tried various ways, who have altered their diet, who have tried exercise programs, who have worked with specialists, worked with nutritionists, their doctor, even gone to Weight Watchers or Jenny Craig. We're looking for people who've tried everything and say, this isn't me, I need help, I need a tool because I'm going the wrong direction. I am going to die early, and I don't like the way my life is. What it is that makes the surgery work so well, and we're only recently finding this out. We've been doing the surgery for a long time, but until this new field of scientific experimentation with animals and doing the procedures on animals and studying hormone levels and genetically altered mice that don't express certain receptors and comparing different groups, we know now that the surgery works because of a lot of the changes in hormone levels of the body, the way the gut communicates with the brain. It changes the bile acid metabolism in our body, and bile acids themselves act like hormones and can cause a lot of the diseases in obese people. Our body has 100 trillion bacteria in us, in our gut, that live with us, that provide a very important part of our health. And obesity alters the types of microbes that live there. And when it's altered, this leads to higher rates of other diseases. When we do the surgery, what we find is that all these processes go back to a normal, healthy state. What we find in people who have normal weight and are very healthy, after surgery, we see the same metabolic profile, the same hormonal changes, the same bile acid changes, the same microbial changes. And so these surgeries act at a metabolic basis. It's not simply making tiny stomachs, people eating less amount of food. It's everything else. That's what leads to people choosing healthier foods. It's physiologic. They are driven to healthier foods. After surgery, people don't crave the foods they like to crave. They crave things they never thought they'd crave. And this is all metabolic. Metabolic diseases like diabetes go away before any weight is lost. The majority of people with diabetes, they're no longer diabetes within 24 hours of surgery. And we know this because we measure their blood sugars every 6 hours. They're on a sliding scale. And after 24 hours, their blood sugars are normal. We're not giving them anything. They can go home after surgery and measure their blood sugars every day. Normal, 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 not taking medications. That's not related to just eating less. That is a profound metabolic change. The reason that people, whether or not they're preparing for surgery, they go on a diet, they really take it seriously, and they drop 20, 30, sometimes 50 pounds or more. Over time, they put it back on. And this is because of the Setpoint theory of body fat, which says that due to all the metabolic derangements, all the abnormal hormone concentrations in our body, bile acids and everything else, that the way our gut communicates with our brain, we have this very high set point where our brain doesn't see us as overweight or obese. If you try and lose any weight, the brain wants you to put it back. If you gain any weight, over time it comes back down. And most people kind of live at the steady state. And for people who suffer from severe obesity, that set point is artificially too high. It's set way too high. And diets and exercise by themselves cannot make that substantial change permanently. And we have not found anything other than weight loss surgery, bariatric metabolic surgery, that can actually shift that set point down to a normal, healthy weight.
The Setpoint theory suggests that no matter what you want to weigh, your brain has a certain weight range and body fat level that it works to maintain within the Setpoint range. This means that you don't control your body fat consciously. Rather, your brain manages it like it does your breathing and heart rate. Your brain receives information through hormone signals from your body fat, muscles, pancreas, liver, GI tract, and sensory organs at all times, and controls your appetite, digestion, energy balance, and metabolism. Once your set point has been elevated, your body works to defend it vigorously. What happens when Amanda starts a diet? She might be able to lose some weight temporarily, but hormone signals from her body change in response to weight loss and tell her brain to increase calorie intake and slow down calorie burn to restore the body fat she's lost. She feels hungrier, and although she doesn't know it, she's also burning calories slower than before. Amanda's body doesn't recognize that her set point is too high and her weight is unhealthy. It only knows to defend her current set point.
There are many types of surgeries that are being performed out there that have been described. In this country today, there are two main bariatric metabolic procedures that are being performed: the laparoscopic sleeve gastrectomy and the laparoscopic Roux-en-Y gastric bypass. There are other procedures that have fallen out of favor, like the laparoscopic band operation with an adjustable band, the vertical banded gastroplasty, which was abandoned after the 1980s, the jejunal-ileal bypass, which was a procedure that came about in the 1950s, and then so many side effects, it was abandoned. But the field has so refined, we're following patients longer, we know what works, and we're right now down to two main procedures, the sleeve gastrectomy and the gastric bypass. Those are the procedures we perform here at St. Agnes Medical Center.
To access the abdominal cavity, small incisions are created. Trocars are placed to serve as passageways for surgical instruments. The surgeon examines the abdomen using a laparoscope or video camera. The average human stomach can expand to hold around 1 to 1.5 liters of food. While in the stomach, food is combined with digestive enzymes. These help break the food down into a simpler form so that it can be digested more easily and absorbed in the small bowel. During a gastric bypass, a small pouch is created in the stomach using a stapling device. The small stomach pouch, about the size of an egg, limits the amount of food you can eat before feeling full. The small bowel is separated into two sections. The lower portion of the small bowel is attached to the newly created stomach pouch. This allows food to pass directly into the second portion of small bowel, where digestion continues. The upper portion of the small bowel is reconnected to the lower. Bile and pancreatic fluids from the liver and pancreas allow food to be digested completely. By altering the anatomy of the gastrointestinal tract, gastric bypass changes signals in the body, resulting in decreased hunger and increased feelings of fullness after meals. During a sleeve gastrectomy, a thin vertical sleeve is created by using a stapling device. This sleeve will typically hold between 50 and 150 milliliters and is about the size of a banana. The resected portion of the stomach is removed. By altering the anatomy of the gastrointestinal tract, sleeve gastrectomy changes signals in the body, resulting in decreased hunger and increased feelings of fullness after meals. Bile and pancreatic fluid from the liver and pancreas mix with food and allow it to be completely digested and absorbed in the bowel. There is no rerouting of the small bowel or postoperative adjustments needed for the sleeve gastrectomy.
These procedures are associated with risks like any other surgery. Today, the surgery is very safe. Risks are something we don't commonly see. And for the vast majority of people, they come in, they get the surgery, it's about an hour and a half long surgery. They wake up with 5 tiny incisions, 5 Band-Aids, up walking day of surgery. Our average length of stay is about 1.5 days, so most people go home the day after surgery, and they're back to their usual activities in 1 to 2 weeks. Can complications occur? They can, like any surgery. All surgeries have a risk of bleeding. If you're doing stapling or connections, there's a risk of leak. There's risks of blood clots, and these are pretty rare. When they occur, we take care of them. When we take care of them, those patients go on to achieve every bit of success. When you're thinking about the risks of surgery, you really have to compare what the risks are having surgery versus the risks of not having surgery and living with the obesity and living with the risk of high blood pressure and diabetes and heart disease and early death. And when you weigh it out, and you do this by studying the scientific literature of studies that have followed these patients for decades, there's no question that today these surgeries are very safe, and it is safer to have the surgery than not have the surgery. So what patients can expect after surgery with respect to weight loss is initially a pretty dramatic drop in their weight. What we generally see is people drop about 5 pounds a week, 20 pounds a month, and that goes on for about the first 3 months. So by 3 months, most people are about 60 pounds down, and then it starts to slow down. And it takes, depending on people's weight before surgery, about a year to a year and a half to kind of reach their final plateau. And a lot of what we do as a team, the nutritionists, the exercise physiologists, our counselor, myself, is we are trying to get people down to their healthiest weight they can by the time they hit their plateau. Now, some people will hit that plateau maybe a little early, maybe they haven't been exercising as they should. Our program is lifelong, and we can intervene at any time and work with people. So I would say that dramatic weight loss at the beginning, slowing down at the end, and then we're really working on fine-tuning. Here at St. Agnes, we really take a team approach. We're a multidisciplinary team made up of, well, myself as the medical director and the surgeon. We have a team of nutritionists who are absolutely dedicated and have been caring for bariatric patients for years. They are involved in our preoperative educational program, preparing patients for surgery. So they're really setting up the foundation for success afterwards. They're involved in counseling after surgery and long-term education and counseling. We have an exercise physiologist in our program specializing in fitness training. We have access to the cardiac rehabilitation gymnasium at the hospital, which is an incredible gymnasium. And so all patients will have an opportunity to interact with our fitness trainer, exercise physiologist. We have a behavioral counselor as an integral part of our team. Why? Well, because it's almost all psychological. There's a lot of behavioral issues involved, and Susan specializes in food addiction and eating disorders, and she's has a very prominent role in our preoperative education program, preparing people for surgery. She's also involved in doing some of our psychological evaluations and really working with people who have psychological issues before and after surgery. And so together we have developed an intensive approach as a team before surgery with a close follow-up after surgery and an ability to actually reactivate intensively at any time for the life of our patients.
My name is Maya Jost, and I'm an exercise physiologist. I'm part of the Metabolic and Bariatric surgical team. So exercise physiologists really help patients coach their way through the process, pre-surgery and post-surgery, to help them gain healthy habits for activity in their lives, finding time for it, making it a priority, and making sure that it's something that they can sustain long-term. All the research shows that exercise and diet have to work together in order for people to be able to maintain long-term results. And so we're really emphasizing that and hoping that our patients will feel comfortable helping us coach them through. We're participating in the pre-surgical education coursework along with the dietitians. And the role of that is really to get the recommendations down. So the requirements for exercise are a little bit greater with bariatric patients than the general physical activity guidelines. So we're helping them understand what the requirements are and then help them break it down into something that's palatable, because it can be overwhelming. So we're trying to make sure that it's not intimidating, that they can get the best results possible. So post-surgical, we have options for patients to come exercise under our supervision. We also want them to feel comfortable coming to us with any problems or concerns they've come across along the way to help us reevaluate their circumstances and help them move forward. Well, it can be intimidating to start a program, especially if the only exposure you've had has not been the most pleasant. So we really try to help patients find something that they enjoy doing, activity that they like to do, activity they can do with their families or their support system. And so that enables the exercise to become part of what their values are. So their motivation comes from what they hope to accomplish, being able to play with their grandkids or go about their normal activities, instead of I have to exercise for so many minutes a day. So by building it into their value system, it makes it easier for them to deal with the idea of exercising regularly.
My name is Danielle Caprelli, and I'm a registered dietitian here at St. Agnes Medical Center. Nutritional guidance plays such an important role in weight loss success and maintaining that weight loss success. The interaction with a dietitian will begin 6 months prior to your procedure, and it will continue on every step of the way. We will start with educational programs to help you form healthy eating habits to help you maintain that successful weight loss. After that, we will meet with you in the hospital after your surgery. We're also available as an outpatient dietitian if you'd like to. We also have our support groups where a dietitian will be involved if you have any nutrition-related questions. Our goal is to help support you in maintaining your weight loss success and your overall health goals.
I'm Susan Hill, and I'm a licensed marriage and family therapist and the behavioral counselor here. And my specialty areas include food addiction recovery and eating disorders, which tend to be a major factor with the development of obesity. I meet with individuals on a one-on-one basis as well as a group setting. So we have the educational program that I also participate in. We have the individual counseling that's available for people who need that extra benefit before and after surgery. And we also have the support group that people can come to, and that's to provide continuous support for people as they transition through the weight loss process and developing a healthier relationship with food. Well, what tends to happen is people have developed a relationship with food, or they're using food in a way that is not healthy and isn't what food was meant to be. So food is meant to be fuel for our body, to provide us with nutrition and energy. And sometimes people have used it as a coping mechanism. So they're using it to battle stress or loneliness or sadness or frustration. And so I help people work through that process. There's a large percentage of people who do have issues with returning back to their original weight because they're missing the psychological aspect of dealing with the issues that have caused them to start using food to medicate in the first place. And so we tend to look at some of those issues and where did this message come of we use food for love, we use food for stress relief, we use it to alleviate boredom, we use it to get through stress or grief and loss, or we use it for celebration or even for happiness. And food was never meant to have those purposes.
So for people who are watching this video and are on the edge, not quite sure if they want to jump in, then I would tell them don't jump in. We do not go around trying to convince people to have surgery. Our patients come to us and they're, almost begging for surgery. They have tried everything. They want to be healthy. They don't want to have these diseases. They want to live long and live great, and they just need that tool. They need that powerful tool, and they want a dedicated team of professionals to help them through this process. What I know from my experience, having done this for 17 years now, is that the only regret I ever hear is, why didn't I do this 10 years ago? All of a sudden you have this energy that you haven't had. People get up at 4 in the morning and they clean their house like crazy, and their family's like a little disturbed by this, but this is something we commonly see. It's really not about the surgery. It's about people looking to change their lifestyles. I am looking for people who want to embrace a healthy lifestyle. There are people who are ready to say, enough. I'm ready to make a change. I am going to become a healthy person. I'm going to make healthy food choices. I'm going to exercise on a regular basis, and I want to work with a doctor and a team of individuals that's going to help me get there. Okay? It's not about the surgery, it's about the person. And so my philosophy is to find these people and encourage them and prepare them, set up the foundation, and with surgery we give them a very powerful tool, and we empower them to use the tool, and we just coach them all the way through till they reach their success. So my philosophy is partnership between us, me, our team, and the patient. We want to add years to people's life and life to their years.